So risk factors, so why do women get candidal vaginitis? Well, lots of reasons. Some women never get them, doesn't matter what happens to them, they never get it. And some women get them very frequently. So antibiotics are a big part of the problem. Because the vaginal milieu or environment is very dependent on a balance between bacteria and fungus, or yeast. And so if you disrupt that and wipe out bacteria, then just like when we get thrush in the mouth, you get opportunistic infections in the vagina. So that's one. Hormonal contraceptives do the same thing. They change the environment of the vaginal epithelium, and it makes it more at risk for certain antibiotics or certain microbes. Contraceptive devices can do the same that are used intravaginally because they'll do the same thing. So if you change the estrogen to progestin ratio in that area, that's what happens. Weakened immune system. So women with HIV, immunocompromised, we'll talk about those and how we can treat them a little bit differently. HIV actually follows the regular recommendations, but those women are at more risk. Pregnancy. Also, again, you get a change in hormonal balance, and that tends to put some women at higher risk. We talked about it when we got to diabetes. If you have women who are coming in with frequent yeast infections, always check an A1C, a blood sugar, because it's a real common comorbidity. And then sexual activity. And I have no idea why yeast infections are not, well, it puts them at risk, and so why women who have no sexual activity or inactive also can get them. It could be from these other reasons as well.
I really was concerned, are y'all able to get onto the material that you need? Because the Wi-Fi thing, they sent that email out.
I don't know, I couldn't get on email, and we just barely got the handout printed out.
But if you didn't download the handouts off of D2L into your computer, you're out of business right now. Are most of y'all out of business?
But they have
the guest
Wi-Fi works is what people are saying.
Is to go back that direction. I don't know what's going on. My computer's okay, but I left my computer in the cradle and I just put it on sleep, so I was still connected. So I think if you're outside and you're trying to get back on,
yeah, Wi-Fi is the
auto routing you, so you have to kind of go the other direction. Well, we'll see. Sorry.
Well, we have papers, so.
Yeah.
Okay.
Except for those that, like, Audrey, who is it? Some of y'all do outline. Yeah.
I downloaded mine last night.
Yeah, you downloaded yours last night.
So you pulled it down before we got here. Okay. All right. We're hitting with the stick.
Okay, so the drugs that we use for yeast infections are the azoles, okay? And they're very effective. We use topical and we have a very strong oral, the fluconazole. So azoles, I don't know, I put in a YouTube, I guess I won't be able to access it. Is there any internet at all?
I got on the guest on the internet and it was fine.
Okay, you know it's 8 o'clock and how much I've left 8 o'clock.
We can watch it at home.
You can watch it at home?
Yeah, that's easy.
Okay. This is a really good little YouTube that talks about how the antifungals work. But this, okay. This also looks at it. So they're mostly cell wall disruptors. And that's how they work. So in the yeast cell, they just disrupt the membrane. It disintegrates, all the guts empty out, and the bug is dead. Just in a encapsulated form. Okay, so in terms of absorption, so when we use the topicals are good because they are very, just like we've seen with other vaginal products, the systemic absorption is pretty low. They will vary. So you'll get some women who will develop allergic reactions, systemic allergic reactions, because there's some absorption. Chlorotrimazole, which is probably one of the more common ones, it has the highest, and tiaconazole has the lowest. So you might kind of keep that in mind. Miconazole is probably one of the more common ones used as well, and it kind of fits in the middle there. Fluconazole we like because it gets around all the things that causes trouble. It has great bioavailability, it's very well absorbed, it's very effective. We can use it for most uncomplicated vaginal candidiasis with one dose. You could give it in the office if you wanted to. So very, very, very easy dosing. And we've gotten down the topicals now to where we can usually, with an uncomplicated, we can treat 1 day, 3 days. So they used to be 7 to 14 days regimens, but now we can usually do it with 1 to 3 days. For a more complicated, and we'll get to this in the handout, we go longer, 7 to 14 days sometimes. All right. So adverse effects are minimal. Sometimes women will complain just because of the nature of the product. Things that are in the product that are inert will sometimes be vaginally irritating. And you've also got an infection set up, so you've already got inflammation and irritation. So you put a foreign product in there, and so sometimes women will complain of burning, stinging. Usually that will go away. As soon as you get the infection kind of calmed down, then those things go away. Fluconazole is a different story. Most of it is GI, but most people tolerate it very well. Liver is usually not a problem because we don't use it for long term. Now when we get to where we're having to use it on a more regular basis, then we're going to worry about liver. Always think, when you are using an azole, always think liver. For several reasons. One of the drugs that I have told you is huge in terms of interactions are the azoles. If you're using them topically, not a problem. But if you're using them long-term orally, they are going to be a problem if they're on other drugs. Okay? So always, it's just one of those big drugs that you always look up. If you're going to add it to somebody's regimen, or you're taking it away from somebody's regimen, you've always got to look at drug interactions, because they're big. They're huge on 2C9, and they're big on 3A4. So some of the bigger pathways that a lot of the drugs go through, the azoles also will inhibit those pathways. So if you've got somebody you've got to put it on long term, then you're going to have to follow ALT and AST. Most people not. This alopecia and chapped lips that have been reported with high dose, I've never seen, but I haven't had to deal with a lot of people on very high doses for long periods of time, just a few, and I've not seen that happen. Okay, drug interactions. So let's look at that section. Okay, so azoles are both metabolized by and they affect the metabolism of their drugs, so it goes both ways. Mostly, they're really strong inhibitors, so they usually are affecting other drugs. So fluconazole is 2C19 and 2C9. So if you look down right below that, warfarin. Anytime you see 2C9, you've always got to think warfarin if you've got a patient on it. Warfarin's another one. I can't keep track. I just assume that if warfarin is involved, there's a drug interaction if they're on another drug. So always, warfarin, azoles. What other drugs have I told you? Always, always look up. Amiodarone, good. Wow, and it's 8:15. That's good. That's good. All right. What other drugs? Give me another one. Okay, cyclosporin, not a very common one. What would be another drug that we put a lot of people on? Middle-aged, cardiovascular disease. Statins. Okay, statins. 3A4. Okay. All right. So with warfarin and fluconazole, now one dose we don't worry so much about. Most in the community clinic, they've already had it before we even saw them. But if they're going to have to be on it long term, it's a 2C9 inhibitor. So you have to reduce the dose of warfarin. So if you're going to put somebody on, and we'll talk about those more complicated yeast infections, you've got to have somebody, whoever's monitoring the warfarin, or you've got to reduce the dose. Rifampin, this is another one. Rifampin affects everything. Luckily, we don't use it very often, but where would you most likely see it in long-term cases? TB, good job. Okay, so TB would be one of the more common. We also use it a lot in prophylactic type of situations. House carriers of certain organisms, we would treat them with rifampin to kill those carriers. So not very common, but whenever it's present, if you are going to add it, you have got to think drug interactions. So warfarin, rifampin, amiodarone, you got azoles, statins. Those are big ones. Grapefruit juice is another one. All right, good job. Okay, so rifampin tends to decrease the half-life of fluconazole. Rifampin tends to speed up everything, speed up the metabolism, so you would have to usually use bigger doses of other drugs. So, next page. The others are the anticonvulsants, because they usually, they're messy because they induce and they inhibit. They induce their own metabolism, remember, and you have to increase the dose over time. They also are metabolizing, or they're going to affect the metabolism of other drugs, and other drugs will affect their metabolism. Phenytoin is a classic example in that area. So those are really the big ones to worry about. Again, you will rarely see this. If you're in family medicine or internal medicine, you're probably not going to see this as much because we don't use this drug chronically. But if you get into HIV or you get into immunocompromise and you have to use this drug on a more common basis, this is where these will pop up. Okay, so let's look under medications to treat. This is more your bread and butter here. So there's a variety of over-the-counter. You'll see that there's a variety of dosage forms. So you see creams, suppositories, ointments. You see over-the-counter and you see prescription. So the reason to know the over-the-counter is that women can go treat themselves for a long time before they come to see you. Okay? Or if they have no medical care, they may do that for many episodes before they come and see you. Okay? So keeping that in mind and using that and asking, well, okay, how have you been treating this? Then you'll have an idea of what's out there. You should know which of the drugs are over-the-counter and which are prescription. There aren't that many prescriptions, so turconazole, fluconazole, I've never even seen gonazole used. It's not a very common one, butaconazole. So those are ones you would write for. The others you could tell women to go out and get. You could write them a prescription, but when they come to the pharmacy, they're going to tell them it's over there.
Yes, that's actually what I did.
It's exactly what they do, unfortunately, or fortunately. Okay, so know which ones are imidazoles and triazoles. Okay, I think I gave that back to you on the page before. Okay. So what you see in just going down there, you've got different strengths. You have different time intervals. So most of the time what you're going to see, if you look down there through, you have 1 day. Teoconazole is probably the only one I think over the counter. It's 1 day. No, Monostat has a suppository. So 1 day, 3 day, 7 days. Now, in talking to GYNs, a lot of them don't like suppositories because they've seen women get extreme vaginal irritations and ulcerations from them sitting there, and in some women they cause a lot of trouble. So that may be of course they're going to see the more unusual. So a lot of women may prefer a suppository over a cream. So these are going to be for the uncomplicated, over-the-counter, treat yourself. When you go down to the prescription products, you see very similar, 1, 3, and 7 days. Which one, does it matter? No. If you've got a first time, I doubt, well they might. If it's a first time, try the one day. Okay? If you get women who won't clear, then the 3 to 7 days makes more sense. Okay. If the woman has a infection and it returns soon thereafter, then use a longer time period for the second. So I'm telling you, there's no rhyme or reason. I would be the most conservative and then advance it based on response and history. Okay. So how do we define uncomplicated? You probably talked about this before. So these are infrequent, they are mild to moderate, they are usually Candida albicans. When you can't get an infection to clear up, always suspect it's a different Candida, because a lot of these products will not cover the other one, the other Candida, non-albican species. Healthy, non-pregnant woman. Okay, that's going to cover the majority of people you would see, and a majority probably will never come to see you, but they may. But it would be good to get that history. Okay, next page is for uncomplicated. They are usually going to respond quickly. Within 24 to 48 hours, they should have their symptoms go away. Oral versus topical, doesn't matter. Oral may be preferred because women don't want to mess with the topical. They're very effective. So there's nothing, it goes to patient preference here. Dosage form, length of time, within reason, cost. So you've got a variety of things. You won't go wrong in your choice. Okay, so fluconazole, when to consider it for first time? Oral, 1 dose, convenience. It does maintain concentration for 72 hours, so that's why, and that's an important concept to remember, or that fact about fluconazole, because when we get into treating people long term, we're going to use that knowledge to treat them. We'll put them on suppressive therapy, and we'll treat them every 3rd day with an oral dose, and it's for that reason. It's very long acting, as most of the azoles are. Again, well tolerated, good cure rates. The disadvantage is that, as opposed to topical, they tend to have a little bit of delay in terms of response. So the other thing you can use, if they've got a lot of itching, and that's usually a big thing. So I was thinking about something, a way a physician one time described that itching, but it's fairly gross, so I won't say it. So anyway, so you can always use, did y'all talk about using a combination of steroid and antifungal externally to help with external symptoms? Did y'all talk about that? Okay, I think I've got it down here a little bit later. That's another thing to look at, because you've got the availability of hydrocortisone over the counter, is that what happens if you use hydrocortisone alone on these infections? They get worse. They get worse because you give the yeast even a better environment. You've suppressed other inflammatory processes that would keep it in check. So usually putting a steroid on a fungus by itself will just make it worse. But you can, for a day or two, give them a combination of a steroid and antifungal just to help with external symptoms. We don't use it internally. Topical products, very well tolerated again with the exception of the local burning irritation. Usually good relief within that 24 hours. They won't get immediate relief if that's what they're expecting, but by the end of 24 hours they usually will have a pretty good cessation of symptoms, especially for mild. Can manage over the counter, don't require a medical visit. So keep that in mind, because they may, if they can't get it cured, then that's when they may show up to you. Let's see, any woman whose symptoms persist using an OTC or who has occurrence within 2 months, they need to be clinically evaluated. Creams and suppositories are oil-based, so if they're using latex products for contraception, now the only thing that would be left would be condoms. They will weaken them. If they're using an old diaphragm, that also could be a problem. Those oil-based products, we don't combine them with latex. Okay. Here's where I put it down. So for severe vulvar, never do it, 8 o'clock again. Inflammation, low potency topical steroids, so like a hydrocortisone with some of the antifungal cream, really is life-saving. Just will make them feel so much better. And they usually do not have to use it more than a day or 2. All right. Questions about those, just general stuff. Okay, probiotics, huge in vaginitis, promoted for vaginal health. There is no evidence, just like we've talked about in nutrition and in GI, no evidence that that helps. So if women want to use it, fine. There's nothing to say it doesn't, that it's not helpful, but I wouldn't promote it as something that's going to make it better. Okay. Treatment of complicated infections. So these are more severe signs and symptoms. This is usually a different candidal species, so Galbrata is probably one of the biggest problems in that area. Pregnancy, poorly controlled diabetes. That out-of-control sugar makes it extremely difficult to get them under control. So working also to get their diabetes under control, if that's part of your purview, is really important. And I use it as a motivator. It's like, we're never going to get this cleared up if you don't take your diabetes seriously and do some things that will get that down. And that's usually a big motivator. Immunosuppression, debilitated patients, so not in good health, and more than 4 or more infections a year. So those are considered complicated. Okay, so for the complicated, you can use fluconazole. And here for 2 or 3 doses, so here's where it comes sequentially. Every 72 hours you have them either take 1 dose, 2 doses, 72 hours apart, or 3 doses, each of them 72 hours apart. So you'd be treating for what, about a week? Or you can use the topical, but here you need to use them for longer, so for 1 to 2 weeks. When these products first came out, they found out that that's what the recommendation was. And then they found out women didn't do it for 2 weeks, and they still cleared up, so eventually we got down to the 1 to 7 day courses. Okay, recurrent vaginitis. This is a real problem in some women. Again, rule out these other causes, other things, and try to mitigate those in order to help with the recurrent vaginitis. So this is defined as 4 or more episodes of symptomatic recurrence within a year. Again, small number of women, but it is just really difficult for them. Usually, often you are working with a different bug, a different yeast, and that can be part of the problem. And what we currently have is not as effective against them, so we're going to talk about some ways to treat those. So in your discussion, ClinMed discussion is, have I told you anything that goes against that? Or is in conflict? Forgot to ask. Okay, so treatment of recurrent. Did you talk about induction versus suppression? Okay. So this is for recurrent. So you're not going to do this very often, but these are for women who you just cannot keep from having an infection. So there's an induction phase, and they can use fluconazole to induce, and we're going to do that same process of every 72 hours for 3 doses. That's pretty powerful. Then we're going to put them on a maintenance dose. So the maintenance can be Clotrip, can be a topical azole, and that can be twice a week. You can also use a topical to induce. So usually they'll recommend doing 1 to 2 weeks of the cream, then put them on every couple times a week. So you've got an induction phase and then a suppressive phase. Usually you'll do that for about 6 months and then take them off. Some women, symptoms will come back. If that happens, the recommendation is to do it, repeat the process, but keep them in maintenance for a year. So you redo the induction phase and then keep them on suppression for a longer period of time. Questions about those? That is a handy one to remember. Okay. Other issues, so compromised hosts, what do you do with those? Those are harder. One is treat longer. So use the 7 to 14 day. And try to correct the underlying cause. Pregnancy, the recommendation is topical product, not use the fluconazole. So there you see increased risk of miscarriage in higher doses and increased risk of birth defects. So stay away from the oral. Breastfeeding. Fluconazole gets into breast milk. But the American Academy of Pediatrics, if that is not a group you're familiar with and you are going to deal with a pediatric population, maybe you're in family medicine, that is a good group to go and look at because they have guidelines on everything. So if you're really unsure what to do in a pediatric population, sometimes there's not data. When we get to peds, we'll find out. There's just very little data compared relative to what we have in adults. So that this group is really good about coming out and saying, okay, here's what we recommend. And a lot of people will quote them. So the American Academy of Pediatrics says. So the AAP. They consider it compatible with breastfeeding. In terms of the topical agents, not a lot of data. I think they're considered fairly safe if you have to use it in a nursing mom. HIV, they recommend doing the very same, so you don't really change a lot for that. Treat them as you would with somebody with immunodeficiency. This is something in the very last one is one to keep in mind. For women who tend to always get a vaginal infection when they take antibiotics, this is a recommendation that you use fluconazole at the start and the end of the antibiotic therapy. That is a very kind thing to do. So if you've got women who always have that and they have to frequently take antibiotics, keep that one in mind. Okay. On the next page is, I took this out of Up to Date. It has some things in it that I didn't say. Some of it expounds more on things that I didn't go into greater detail, and so it gives you a lot of good guidelines and information. They will mention boric acid in here. Another product you maybe have heard about is gentian violet. So gentian violet and boric acid have been used in the past. Gentian violet's messy because it stains everything. But sometimes it's used as an adjunct, or if women cannot use other products, it's not as effective as the others, but gentian violet may be a product to consider. Boric acid, I've read different things here. They recommend the boric acid. Some will use it as a suppressive instead of having to use an azole. Using intravaginal boric acid, 600 milligrams daily for 14 days for if you think you're dealing with a non-albacan candida species. So I'm not going to test you on those. I'm just telling you they're out there. GYNs use them, and they're probably best left in their realm as well. But if women tell you, I use boric acid, now when you think boric acid, what do you think? I think roaches. That's what's in roach bait is boric acid. Yes. Borax, mule train. You all are too young for that. But for washing clothes, some of you are going, yeah. Borax is boric acid. Okay. It's very toxic. I mean, it's very lethal to kids. So you have to keep that in mind. Okay. Do you want to take a break? A lot of you are struggling. We can break now and then come back and do dysmenorrhea and endometriosis. What do you prefer? Okay, let's switch over to dysmenorrhea. So we'll do it first and then we'll come back and do endometriosis. So go to page 16. So what did you learn about dysmenorrhea? Painful, okay. Yeah.
A lot of causes.
Pardon?
There are a lot of different causes.
Lots of causes, what would you say? Lots of bleeding, okay. More abnormal pattern, is that what you mean?
Well, they can like have like really big flow.
Yes.
And
So heavy, long flows. Okay, anything else? Fairly common, yes. Who's it most common in? The old women? It's usually the younger women. It's very common, so using common things to treat it. If they do not go away, if common things do not resolve it, you need to think other pathology. So what would be another common reason for dysmenorrhea?
Cervical stenosis.
Pardon what? Endometriosis is you need to think of that. What else did someone say?
Cervical stenosis.
Cervical stenosis is one of them, yes. So think other causes for that dysmenorrhea. Okay. Usually as women get older, those will go away. As they've had babies, those tend to decrease as well. Okay, so let's go down to treatment options. A lot of it is reassurance. I don't know how far reassurance goes, but I guess maybe to say it's normal. I think that's more is putting a name on it that this is a common thing. This is not it doesn't mean you're dying, even though they feel like they are. So heat, exercise, relaxation, so a lot of lifestyle things go along. Heat has been shown, topically applied heat, has been shown to be as effective as NSAIDs for some women. So I think I put a picture. Yeah, Pharmacare makes one that is more, I mean, they make a lot of different products, but this one they make just for menstrual pain or dysmenorrhea. Women who exercise tend to have less. We'll talk about some other things dietary-wise that also, that's next. Okay, so heat, we talked about that. An abdominal wrap for 8 hours. The bigger thing would just make sure that they are aware that this could burn them and be careful about that. Really, Tylenol has no place. It just does not have enough effect on prostaglandin. This is a prostaglandin mediated. It's thought that it is an imbalance, but it's just the balance of prostaglandins at the time of menstruation. There are arachidonic acid derivatives in the endometrium that are thought to also increase that in women who have very severe. So Tylenol is just not gonna work. Exercise does reduce menstrual symptoms, so getting women to get up and have a regular exercise program. So here's some dietary things that I have found that that claim reduction. Low fat vegetarian diet for 2 months on. So all the junk that you want to eat when you have your period probably doesn't help. Another were adolescents were vitamin E, 400 to 500 international units 2 days before menses, continuing 3 days in. The other are dairy products. So 3 to 4 serving of dairy products daily lowers the risk of dysmenorrhea compared to those who consume no dairy. I have no reason, I have no idea why. Other were vitamin B1, B6, pyridoxine. Fish oil supplements also have some claim to decrease. So I wouldn't probably rely on these solely, but they might be good supplements, or for women who want to not use an NSAID or for whatever reason, this might be some things, other things to try or to suggest. So a compilation of things is probably going to help. Yeah.
Does Midol have acetaminophen or ibuprofen in it? Isn't it? Which is funny because
Midol, isn't it a combination though?
it's
like
there's
caffeine and
there's
caffeine
caffeine
or
and
mild
there's like
diuretic.
a diuretic in it, but as far as
I think
pain
it is
relief,
acetaminophen.
isn't it? Which is funny because Tylenol's next one.
Explains why I never use Midol.
Okay, medications. So it's non-steroidals. Because you've got those prostaglandins everywhere, they seem to help with a lot of the symptoms that you necessarily wouldn't think about. So hypercontractility is under the influence of prostaglandins. Then remember, lots of prostaglandins in the gut. So the nausea that goes along with dysmenorrhea can also be helped with the use of the NSAIDs. So NSAIDs are first line. They should, in 90% of women, they should provide relief. If not total, at least enough to make it tolerable. And we're usually only talking about a day or two. They're over the counter, relatively inexpensive, they're widely available, so easy for women to get a hold of. So at the start of menses, to me this is very sensible, but first, with the start of symptoms, they can be used. It's recommended you start with a phenylpropionic NSAID. I know that we don't tend to use those terms, but this would be ibuprofen, naproxen. Now, the one big difference is have them take it on a regular schedule. With pain, when you're trying to manage pain, it is always better to be ahead of it than chasing it. The more you have to chase pain, the worse it usually gets. So tell them, I want you to take it. Naproxen is twice a day, ibuprofen 3 to 4 times a day. Tell them to start it, take it that way for 2 days instead of PRN. And always take it with food. Mefenamic acid, this is Ponstil, is another one that has, if those don't give relief, just think about Ponstil. It is a little bit different. It inhibits prostaglandin synthetase, but it also will act on the prostaglandins as formed. It's the only one that I know of that will do that. So if those other two don't work, you might consider Ponstil instead. Probably others would work, but these have some data behind them, and so that's why they're recommended. All the contraindications to NSAIDs that we've ever talked about also apply here. We usually don't have to worry about renal because they're young. But look at some of the other things. Aspirin allergy. Who tends to have aspirin allergies? Asthmatics. So about 10% of asthmatics will have a triad of aspirin allergy, asthma, and nasal polyps. Okay? In those people, be particularly careful. Some people in the past were allergic to these products because of the dyes they used. They've gotten rid of a lot of those, so that probably isn't so much the problem anymore. GI ulcers or inflammation. So if they've got GI disease, then you're going to have to think hard about how to use that. Renal dysfunction may be in a few women, it is going to be in the majority. Your diabetics, long-standing, maybe as well. In late pregnancy, we don't want to do that. Increases bleeding risk. interferes with that patent ductus. Negative effect on ovulation. This is something we rarely talk about, but prostaglandins play a role in ovulation. So for women who are having difficulty conceiving or they're worried about it, use a COX-2 selective, like COX-2 inhibitor like Celebrex. If they are really having trouble conceiving, avoid the prostaglandin, these products altogether. Okay. All right. Questions about the NSAIDs? One you're from a drug you should be very familiar with at this point. All right. So another, remember the non-contraceptive benefits we talked about with the estrogen-progestin combinations? Well, here it is. So relief of cyclical problems, including dysmenorrhea, the estrogen-progestins will do that. So if you are, because they inhibit ovulation, and they greatly decrease symptoms. So if you've got women who want a contraceptive and they're having dysmenorrhea, you can kill 2 birds with 1 stone. You can use, and it doesn't matter, you can use the monthly, the extended, you can use the shortened hormone-free products, you can use the continuous. If you have women who really have problems with dysmenorrhea, even on a monthly basis, that on monthly products you can move them to continuous products. Okay. Most women who are put on these products, even on monthly basis, 21, 28-day packs, they are still going to have great relief if they don't want to be on the continuous. Progestin-only products, not studied as well, but most of these products over time will induce amenorrhea. So over time they would get relief. They will not probably get as quick relief as they would with an estrogen combination product. Management of treatment failures. Okay, you can use them together. You can use NSAIDs with the combination hormonal products. If that is not addressing their, or giving them relief, think other pathology. 90+% of women are going to respond to these. So there's going to be a few, that's where you need to think other things. Now, it could cover up a mild endometriosis because we use birth control pills to control endometriosis because we can arrest those endometrial implants that cause problems during and create pelvic pain. So they could mask a mild endometriosis. All right. Okay, we're done with those exciting topics. So let's take a break and we'll come back and do endometriosis, and we'll probably be done early.